those of you that I know, it's great to give this talk for you guys. It's a pleasure and an honor. And then also for those of you who don't know me, my name is Sunil Patel, one of the urologic oncology fellows at Johns Hopkins and a clinical instructor here, and just going to give you a talk today on renal cell carcinoma and nephron sparing surgery. So really just going to focus quickly on really the incidence, risk factors, types, staging, but really focus the bulk of the talk's going to be on the management and surgical principles, and have a quick video that I can show you guys as well. So for the US data for 2021, there's roughly around 76,000 new cases, with kidney being the 6th most common in men and 9th most common in women, accounting for roughly 13 to 14,000 deaths. However, only 2% of global cancers diagnoses and deaths. And if you really look at the incidence, though, the incidence has gone up over the years. However, the deaths have remained relatively stable. And this is kind of still persistent into the most modern years. And really the reason why we're seeing this is the kind of more rapid use and widespread use of cross-sectional imaging. So we're catching kidney tumors earlier on, and that's why we're seeing them. And we can see, though, at the time of presentation, localized kidney masses are the vast majority, roughly around 65%, with some regional locally advanced disease accounting for 16%, and roughly 16 to 20% presenting with metastatic disease. So not a trivial number are presenting with metastatic disease. Again, the risk factors kind of known to all you, but them being a male gender, advanced age, so the median age is roughly around 64 years of life. The modifiable risk factors are smoking. Smoking cessation actually is still protective, and so if patients have stopped greater than 10 years, it is protective. Obesity with a strong predilection in women who are obese, hypertension, and certain exposures. However, most of those are very low level of evidence. And then you have your hereditary renal masses, as well as patients who are ultimately on dialysis, and those having renal cysts progressing to papillary RCC, which only accounts for about 2%. If you look at the renal masses, just quick, there's a big and really heterogeneous list of renal masses, both malignant and benign. And really, we're today outside the scope of the talk, but I'll mention really why this kind of comes into play for one of the management opportunities. And again, Bosnia criteria really help us kind of determine the CT scan appearance of a renal cyst or mass, and help us determine whether they're more likely to be malignant or more likely to be benign. So ranging from 1 to 2F, 3 and 4, where 2F and on you have to really monitor or intervene on. And just quickly, clear cell RCC, as you all know, is the most common RCC, accounting for 70% with a genetic alteration in the von Hippel-Lindau altered gene. Papillary type 1 and type 2 being the second most common, roughly 10 to 15%. Type 2 being the more aggressive disease, and type 1 being the less aggressive. Chromophobe, which is similar to oncocytoma. Oncocytoma is the benign kind of spectrum of it, where chromophobe is the malignant spectrum of it. However, they are sometimes almost determined, or kind of treated in the same way. However, oncocytomas we classify as benign. And really the hereditary RCCs quickly, again, outside the scope of this talk. However, it's kind of good to know really some of the clinical manifestations of these hereditary syndromes, because that can help kind of cue in terms of how aggressive or which type of RCC they have and how aggressive that histology is, and that can help change your decision making in terms of what type of intervention you want to propose, or it can also determine whether you want to perform a radical or partial nephrectomy, which I'll talk about in a little bit. Okay, so going through the clinical stages, as we all know, clinical T1A is less than 7 centimeters substratified between A and B, and then T2, T3, T4. And then we have our nodal and metastatic staging. And really this is our NCCN kind of algorithm in terms of the primary treatment, which should be recommended for patients. And we can see that partial nephrectomy is actually enlisted for all clinical stages. However, really the gold standard in stage 1. However, stage 2, stage T1B, T2, you can choose a partial nephrectomy in select patients, and we're going to kind of go over that in detail. And so when we're really looking at our localized kidney masses, we really have several options in our armoire. Active surveillance, focal therapy, SBRT, which I'll briefly talk about when that's just radiotherapy, partial nephrectomy, and radical nephrectomy. And active surveillance are really held for elderly patients, patients with CKD, patients who have like CKD or other medical comorbidities and really small renal masses, or less than 2 to 4 centimeters. And focal therapy too is another one of those where usually used for patients with medical or multiple comorbidities. And the rationale behind kind of active surveillance is really, if you look at the US data, roughly 20 to 40% of masses less than 4 centimeters are benign. So we're removing a lot of benign renal masses. And if you really look at even those patients that are not benign, patients who have tumors that are less than 4 centimeters, 80 to 90% of those masses are low to very low malignant potential. So therefore, there should be another alternative of how to manage these patients. And that's where this disarm cohort came in. That's the delayed intervention and surveillance for small renal masses, which was started at Johns Hopkins by Dr. Zoloff and Dr. Philip Perazio. It's a multi-center cohort now. And it was first opened in January 2009. It's the largest prospective active surveillance for renal masses in the world. And we actually just completed our 10-year update. You can see the algorithm here. However, it's really confined to patients with small renal masses, less than 4 centimeters initially, and they have this kind of strict criteria of how they follow the surveillance program. But really, the goal of this is, if we look at our initial data from the disarm trial, we can see cancer-specific survival being very similar between patients undergoing active surveillance and primary intervention. So the rates of people progressing on active surveillance are very low, and they're not dying from their renal mass. However, if you substratify that and look at all those patients and look at all the patients and looking at all interventions, including partial nephrectomy, radical nephrectomy, ablative procedures, and active surveillance, the active surveillance group you can see is 66.1% at the very end at 7 years. And the reason why, and this is overall survival, and the reason why this makes sense is because our patients that we're selecting for active surveillance have other medical issues. So they're dying from cardiovascular disease or pulmonary disease and not dying from their renal mass or their renal cancer. So therefore, intervening on those renal masses may be too soon. And so therefore, active surveillance is a better option for them. Moving on to the next is cryoablation. It's another form of nephron-sparing surgery, and patient selection is very key for patients undergoing ablative therapy and should be selected for patients with less than 3 centimeters mass. Posterior masses are more amenable to percutaneous approach. The anterior masses are more amenable to the laparoscopic approach. And exophytic masses are preferred, and that is just because the treatment zone does extend beyond the tumor, and therefore really central tumors, you put the patient at risk for renal pelvis injuries and can potentially, if they're lower pole, ureteral injuries as well. Argon gas is the type of gas therapy that we use, which is cooled to minus 40 Celsius, and you can undergo 2 freeze-thaw cycles ranging from 8 to 10 minutes. Like I said, the treatment zone does extend about 5 to 10 millimeters beyond the tumor, and that's to make sure you get in adequate margins. And really, success of cryoablation is determined by loss of enhancement on CT or MRI at that first scan. However, that does not really correlate to disease or recurrence-free survival. And I'll talk a little about it in a second. But really, these patients need to go their first scan and then 6 months and then annually for 5 years. And the incomplete ablation is enhancement on that very first scan, which you need a repeat ablation. Or recurrence, which you initially have an period of loss of enhancement followed by an enlargement or enhancement. And those patients should really be managed by a follow-up biopsy to kind of re-diagnose them and restage them. So you can see here, it's really hard to determine this picture. However, this patient has a left posterior partially endophytic mass. You can better see on this next scan where the percutaneous approach was attempted and the probe was placed in 2 cycles were performed. And you can see the post-treatment scan, a loss of enhancement on that posterior endophytic mass. And this is a CT urogram with a delayed phase. And you can see that there's no injury to the collecting system. And so there are some indications for these patients. And this patient was one of those patients that were elderly, multiple medical comorbidities, specifically pulmonary and cardiovascular disease, however, had a slowly growing mass and wanted an intervention. Therefore, cryoablation was chosen. And if you look at this big study from the utilizing the SEER database, they really compared partial nephrectomy comparing to ablative therapy, so cryoablation and on RFA, which is radiofrequency ablation. And you can see that overall survival was similar amongst partial or RFA and cryoablation. So both of those are similar in terms of cancer-specific survival and overall survival. However, partial nephrectomy, specifically in masses greater than 2 centimeters, had a better overall survival as well as cancer-specific survival. So so when counseling patients, you really need to quote the chance of recurrence with ablative therapies, because there is a higher chance of recurrence compared to a partial nephrectomy. And then quickly, SBRT is a really new option and kind of new and coming right now. This is some of the earlier data that we have in upper tract as well as RCC in the use of radiation therapy. And in this small study, 45 tumors were treated, vast majority were RCC, however, some had TCC as well. And some of the patients would have been anephric if the patient underwent a nephrectomy. So they underwent radiation therapy, and you can see the very short follow-up in small n. However, there was local tumor control rate at 9 months only. So there is some potential. However, larger studies are being done right now, but it's theorized that this can potentially be a new form or another ablative option for patients with a lot of medical comorbidities. Okay, so now moving on to partial nephrectomy. So really the gold standard for clinical T1A masses. The first intentional partial nephrectomy was performed in 1887. And since then, a lot of advancements have been done. Obviously back then, everything was being done open. And then the urologist, when urology became a really big field, our flank incision really took hold as the primary means of doing a partial nephrectomy or nephrectomies. And nowadays, at least especially in the United States, minimally invasive approaches are being utilized, with robotics now taking over laparoscopic. However, you can utilize partial nephrectomy in certain patients in clinical T1B masses or greater. However, those patients really had to be selected carefully. And radical nephrectomy are really used for patients with greater than T2 masses, normal contralateral kidneys, and no evidence of proteinuria or evidence of further renal or suspicion for renal decline. And so absolute indications for a partial nephrectomy. So it's indicated when a patient, if the patient wanted to go a radical nephrectomy, you would render that patient anephric or needing dialysis, as well as patients with bilateral renal masses, as seen in this photo right here. And that can be intertwined with an absolute and relative indication, especially for our patients who have these hereditary syndromes. A relative indication is, like I said, can be hereditary forms of RCC, so Burghardt, Dubé, von Hippel-Lindau. However, pre-existing renal disease, so patients with CKD or compromised GFR, you can see in this ultrasound, this patient has medical or evidence of medical renal disease. And so those patients you really need to kind of watch out for. And the reason why is that there's been a lot of studies really talking or kind of investigating renal function, as well as how it correlates to overall survival, but how it correlates to, how it differs between partial and radical nephrectomy. And so this is a large study performed from the Memorial Sloan Kettering Cancer Institute. And really it was one of the first ones really looking at chronic kidney disease after patients undergoing partial nephrectomy, as well as a radical nephrectomy. And they really found that patients who underwent partial nephrectomy had a probability of freedom from developing CKD or GFR less than 60. So that was really a big swing and the change of paradigm on how we started pushing for partial nephrectomy more. Another large study was a retrospective review done by the Cleveland Clinic using their database from 1999 to 2008. And they found that they really stratified patients into medical CKD versus surgical CKD. And they found that patients who had medical CKD had a faster rate of decline in their GFR over years compared to patients who had a surgical CKD. So surgical CKD, for instance, someone who underwent a nephrectomy and then developed CKD, the rate of decline of their GFR after surgery was less than medical. And so by extrapolating this into patient and selection and decision what surgery to perform, patients with medical renal disease need to really be counseled and considered for a partial nephrectomy, because we know, even though they may not be on dialysis now, if you perform a radical, that's going to further speed up their chance of developing dialysis. And we know because their GFR is going to fall faster than someone who undergoes a surgical or has surgical CKD. And as we all know, CKD, this is a large study from the New England Journal of Medicine, but CKD and developing CKD is linked to a lot of issues, and specifically risk of death, cardiovascular events, and hospitalizations. And you can see very clearly that patients with low GFRs have a very high chance and probability of being hospitalized, developing cardiovascular events, and dying from their issues. So therefore, as urologists, we really help try to prevent patients from developing CKD due to surgery. So now kind of shifting gears in terms of oncologic outcomes and controls, initial and early data really from institutional databases really showed that partial nephrectomies, when patients are obviously, all these studies have some element of surgeon bias and selection bias. However, if we chose patients correctly and that their 5-year disease-free survival was great, and their chance of recurrence was very low. However, these were some smaller studies. And so then a large prospective multi-institutional randomized controlled trial was developed, the EORTC 30904, which was a big study published in 2011, a randomized non-inferiority trial from 1992 to 2003. And really it was to determine if Nephron sparing surgery was not inferior to radical nephrectomy. There's a couple issues about this study, which I'll go into, but it's originally tried to accrue 1,300 patients, and was inclusion criteria was for patients who were very healthy and had normal contralateral kidneys, and their renal masses were less than 5 centimeters. And you can see kind of the two arms over here. And if you look at the cancer-related deaths, there's very small events that are relatively low number of events in this. And the reason why is, if on the previous slide, they didn't accrue anywhere near 1,300 patients. So that was one kind of big issue with the study. However, it did give us an insight into the hazard ratio or for progression, which was not statistically significant. And we know that they also found the complications and reported then that bleeding was more common with Nephron sparing surgery, which was very similar to a lot of this retrospective studies, and a smaller risk of a urinary fistula, and also longer operative times as well. And so really the big key conclusions from this were, it was a limited study because that did not reach their sample size, and 55 patients did switch treatments, but it did support oncologic equivalence. However, it was very few events, but the really unexpected results were that there was a worse overall survival in Nephron sparing surgery compared to in the intention to treat analysis. So there were some limitations in this. However, overall, it did show us that they did have some oncologic equipoise. And given in that study, those patients were very limited to clinical T1 masses and masses less than 5 centimeters. However, there's a subset of patients that ultimately get a partial nephrectomy and are upstaged to pathologic T3A or greater. And so this is a multi-center retrospective analysis that I helped perform and lead back when I was a resident. And we really looked at those patients, and we looked at 929 patients and really looked at patients who had clinical T1A and T2 masses who underwent a partial nephrectomy and were upstaged to PT3A, and looked at their functional and oncological outcomes. And partial nephrectomy had a lower delta GFR, so it didn't change the patient's renal function statistically significant. It barely did. So 6.1 versus 20 compared to a radical nephrectomy. But more importantly, that it actually showed a little bit of overall survival benefit. And we kind of know that based on all the preservation of GFR leading to overall survival benefit, and cancer-specific survival and recurrence rates were exactly similar in both arms. So patient selection and understanding that doing partial nephrectomy in certain patients with clinical T2 masses is, even being upstaged to PT3 is safe, both from an oncological standpoint and can potentially help patients in the long term. So really, many studies show that partial nephrectomy is superior to radical nephrectomy in preservation of kidney function. There's some association with improved overall survival due to the cardiovascular events, as well as just progression on CKD. And we know that oncologic control is similar. So really, based on the kind of guidelines, is every patient with a clinical T1A max should be offered a partial nephrectomy, any patient with a solitary kidney, but also patients with, we know who have CKD, we should try to preserve as many nephrons as possible. And it is safe from an oncological standpoint for patients with greater than T1B masses. However, patient selection is key. And so now kind of shifting gears into really the surgical approach. So really the mainstay of partial nephrectomy can be done through open or minimally invasive approach. The open approach, the flank is by far probably the most commonly utilized. However, anterior subcostal or a mini laparotomy can be used as well. Minimally invasive approaches, both laparoscopic and robotic approaches are being used. Like I said, robotic approach has been kind of taken over the laparoscopic approach. And that can either be done the retroperitoneal approach or a transperitoneal approach. And the retroperitoneal robotic approach is really limited to posterior tumors or patients who have very hostile abdomens, meaning they've had prior multiple abdominal surgeries, XLAPs, or a lot of medical issues with cause like pancreatitis, or knowing that they're going to have some sort of inflammatory response in there. But at the end of the day, like any surgical paper or any surgery that you perform, this approach should always be determined by surgeon comfort. So if an open anterior approach the surgeon is most comfortable with, that should be the approach the patient is offered, because we know from a lot of data that that's going to be at least the best patient outcomes. And really in partial nephrectomy, and all of my mentors have taught me this, and I'm sure that you guys all aware, preparation is really key. So knowing the anatomy inside and out is always imperative to the operation, like any operation, but for renal and retroperitoneal surgery, it is key, because you can have aberrant anatomy, you can have vessels that are crossing, you can have retrocaval vessels, especially on the right or anterior to the IVC2 on the right side as well. You can have large lumbars, you can have multiple renal arteries. And so preoperative imaging is crucial, and as well as intraoperative ultrasound for the resection of the tumor, understanding how endophytic and the margins of the mass are, so to avoid positive margins. Like I said, the approach is key in terms of is a part of the preparation as well. Having all your material and sutures available is always imperative as well, making sure that if you know that this is going to be a tricky dissection, say it's on the right side, and you may need to dissect part of the kidney off of the IVC, say it's a locally advanced tumor, then yeah, you just make sure you have some prolines available to make sure you can close those if you make a hole in the vessel. But also mobilizing and defatting the kidney, taking the time, whether that's 5 to 10 minutes more of setting up your partial nephrectomy. That is going to lead to better patient results, as well as decrease your ischemia time, which we'll talk about in a minute. And like any retroperitoneal surgery, as well as any kidney surgery, hilar dissection and control is key. That is ultimately the mainstay of the procedure, and really identifying your vessels and identifying accessory vessels, and then making sure that you have complete hilar control. Left side, obviously watch out for the large lumbar veins, and sometimes the SMA can take off very close to the renal artery, and some people confuse it for a lower pole artery. So sometimes just identifying the anatomy, making sure that that is very clear. And on the right side, when dissecting the posterior plane and lifting up on the kidney, sometimes since the right renal vein is short, you can run into renal avulsion issues. So just being cognizant of that. And so after the kidney has been, the tumor has been isolated, then comes the resection, which most of the time we're clamping the kidney. And kidney metabolism, as you all know, is a very aerobic process, and cooling is effective at reducing the damage. And that's really been extrapolated from our transplant literature. And that's kind of should suggest that 3 hours of cold ischemia time really can be well tolerated by the kidney. However, there's no real established cutoff for cold ischemia time in a partial nephrectomy setting. And I know there's some papers that are out there looking into that, and really the goal is less than 40 minutes. However, warm ischemia time really is kind of been clearly delineated as less than 25 minutes. And sorry. And that's really out of this bigger study from Dr. Thompson. And this is a big multi-institutional study from Mayo Clinic, USC, as well as Cleveland Clinic. And really they found that every minute does count when the renal hilum is clamped during a partial nephrectomy. And you can see that with every minute clamped, there's an associated 5% increase in renal failure over the years. Again, this does not really account for parenchymal loss, which I'll talk about in a little bit. This just purely accounts for ischemia time. So preparation, like I said, is key, and this can minimize your clamp time. And resecting of the tumor is there's numerous ways to do this. However, we'll talk about another approach on the next slide. However, really identifying the tumor, mobilizing everything like we discussed, but then clamping the artery first. Clamping of the vein is really determined based on the surgeon preference. Certain instances, we don't clamp the renal vein. For one reason why is that you can get the congestion can be a little overwhelming. Sometimes having the renal vein open, you can decrease that renal congestion. Clamping the renal vein does allow for less back bleeding, and it can help suture, and you can help visualize those larger renal or vein defects after the resection. So usually for larger endophytic resections, we do clamp the vein. However, it's not necessary. And the closures really are dependent on surgeon preference as well. Really, all collecting system entries need to be closed by some sort of absorbable suture, such as monocle or PDS. And then really all larger vessels and veins should be suture ligated with a proline that helps decrease the risk of pseudoaneurysms. And the cortical layer and a medullary can be closed however way that the surgeon prefers. And that's really can be done actually off clamp. So usually minimizing taking off your surgical clamps after the big vessels are closed, and tolerating a little minor black bleeding is completely acceptable. And then the last tidbit is really the use of hemostatic agents is, again, very kind of dependent on the surgeon preference. Really no data is available or really good in terms of one hemostatic agent being better than the other. But hemostatic agents are very costly. So that's just to note that not all surgeons use it because there's no really good level 1 evidence, and it is quite costly. And a good rhinorrhaphy should do the trick. Let's go a little bit on enucleation. So enucleation is a form of kind of a tumor resection. And really you can see on the far right that that's a traditional partial nephrectomy where you have this excisional volume loss or parenchymal loss. And you also get this devascularized volume loss due to the resection. And enucleation, though, you tend to find the tumor pseudocapsule, which the tumor pseudocapsule it's due to chronic inflammation from the cancer, and it can range from about 1 millimeter to 1.5 millimeter thick. And you could tend to find that space and dissect that tumor out of around its pseudocapsule that it forms. And that leads to less excisional volume loss as well as less devascularized volume loss. And that's part of the parenchymal loss of a partial nephrectomy. And that's less than the traditional partial nephrectomy. And usually we use it for our tumors near the hilum or collecting system because it does preserve more parenchyma, and where doing a rhinorrhaphy is technically difficult. So you want to maintain as much normal tissue as possible. And cancer-specific survivals are similar to a partial nephrectomy. So you just got to make sure that you get into that right plane and not cutting into the tumor. And if there's always concern, you can always go back to the traditional partial nephrectomy. And just briefly on the surgical complications. So hemorrhage, we've all probably seen this after a partial nephrectomy. Usually an arterial hemorrhage is due to an insufficient suture ligation of a larger segmental branch of the renal artery or one of the interlobar arteries. And you've really got to just suture ligate those. If at the end of the rhinorrhaphy and the clamps off, you see pulsatile flow, just undo the rhinorrhaphy and suture ligate those vessels. And you need to really just explore those patients. Venous bleeds, you tend not to see, it's a small ooze. You can most of the time treat those patients like a trauma patient. So bed rest, just make sure, monitor their hemoglobin and just treat them expectantly. Most of those patients don't need an intervention and they will stop bleeding, and especially if they have no coagulopathies. And then you have the pseudoaneurysm. The pseudoaneurysm can be seen, usually classically seen in a patient who has a partial nephrectomy with significant hematuria. And that's not usually immediate post-op. That's usually due to an arterial bleed, but it's usually seen post-op day 5 onwards. And those patients can be very ill. And in certain instances, if the hospital has interventional radiology, that's usually the modality of choice where they go for selective embolization, where they go for angiography, and you can see the pseudoaneurysm right there. And you can see the little bleed, and you see how the interventional radiologist coils it in that mid to lower pole right there. And you can see how that kind of bleed, that pseudoaneurysm has been resolved. So that is a mainstay of how to treat pseudoaneurysms. But again, decreasing that is really on the surgeon to make sure the suture ligation of all those vessels are complete. Other surgical complications are adjacent organ injury, really seen on the left side. As the right side too, for liver injuries, you can cut into the liver sometimes, but the pancreas, you can get into the tail of the pancreas. Really had to have a high intraoperative and postoperative index of suspicion, and really just those are the patients with prolonged ileus and their drain content is persistent. Usually consult your interventional radiologist, or you can go in and places to have your general surgery colleagues help you out and place a drain, and really just go slow with advancing their diet. A urine leak can range anywhere from 5 to 25%. It depends on how endophytic and how complex the repair is. And really those patients can just be managed with a ureteral stent and a Foley. Sometimes they can be managed with, they may need a perinephric drain if they have a large urine leak and a urinoma and it's causing an infection. Percutaneous nephrostomy tubes are usually these patients who have large leaks tend to have had a large partial nephrectomy, and getting a percutaneous nephrostomy tube through healthy, viable kidney tissue is sometimes complex, and sometimes it can be more difficult for interventional radiologist or even a urologist to place a nephrostomy tube through healthy parenchyma. So usually a Foley, catheter, and stents should do the trick. And then the dreaded one are the delayed strictures, ureteral strictures, and that can usually be due to some inadvertently ligating a lower pole vessel or clamping a vessel or dissecting it off. And then sometimes you can get a thrombus too from a clamp, which I've seen twice before, and just from one of the laparoscopic clamps. And so sometimes those patients end up developing a lower pole vessel thrombus, and they just have to be treated expectantly. And just briefly on the follow-up, all these patients, like you guys all know, need follow-up. So less intense for active surveillance and ablative therapies. Again, after a partial nephrectomy or radical for stage 1, within the first 3 to 12 months, and then annually for 3 years. But then the more advanced stages, you really need to keep an eye on these patients because they have a higher chance of recurrence. So really the big take-home points are active surveillance should be utilized in small renal masses as a form of nephron sparing approach. Even though it's not surgery, it's can help decrease the amount of interventions you need for patients. Ablative therapies can be beneficial as well. However, we know that ablative therapies, RFA and cryoablation are equal to each other, however, have less cancer-specific survival than a partial nephrectomy. Partial nephrectomy should be utilized for any solitary kidney or bilateral renal masses. Preparation and approach is key, and really repair focuses on hemostasis, so suture ligation and a good cortical-medullary closure, and collecting system closures to prevent urine leaks, because urine leaks can cause a lot of issues and delay patient healing. And so those should be really the focuses of the renorrhea. So we're going to quickly go through one video. So this is a patient that had already had a prior nephrectomy, so had a solitary kidney and had 2 renal masses on the right kidney. And you can see there's one interpolar anterior mass right there. And you can see another second anterior and lower pole, mainly exophytic, right there. You can see it's smaller, but heterogeneous. Here's the robotic approach. I'll pause this real quick. So the 2 left arms are for our instruments. So the grasper The second to the left is usually our bipolar cautery. The assistant is the 12 millimeter port, just inferior to the umbilicus. The 12 millimeter port in line is for our camera, and then the far right is our monopolar scissors. And this was the SI setup, however, usually used SI or XI. Really, again, start off the case with mobilizing the kidney, getting off the liver attachments, and mobilizing and removing, reflecting the bowel off the retroperitoneum. You can see here, you can see that perfect plane between the retroperitoneum and the peritoneal space. And now this is just kind of dissecting out near where the hilum will be. And you can see the vena cava down below. You can see this patient has multiple renal veins, and you can see the artery pulsating back there. And now we're just creating a space between them. And now the hilum is completely dissected out with clear renal artery visualized in both renal veins. And now really is the defatting and mobilizing the kidney completely and exposing both of those renal masses. So here's the ultrasound. You can see the tumor on the bottom right there, and that's ultrasound of the upper pole mass, and we'll just marking that out. And note, we have not clamped, and we're just marking, pause real quick. We marked off the second inferior one, and since this patient has a solitary kidney and this inferior pole one is mainly exophytic, we opted to do this off clamp, and that is to help preserve and decrease our ischemia time and preserve renal function. So since it was a very small exophytic partial, we would tolerate the blood loss and just suture ligate this one first before proceeding with a clamp and are performing our second partial. And you can see there's a segmental branch. And so the segmental branch is clamped, and again, we left the renal vein unclamped on this one. You can see dissecting the larger one off and completely taking it out, and now performing our suture ligation with a proline and closing off our tiny vessels that we see from bleeding. And now completely have removing our clamps after our renorphy and making sure there's adequate hemostasis and just kind of cinching down with our lapartize and making sure it's completely done. And those are both the tumors with all negative margins. So those are just videos. I just want to thank Dr. Derwish, Dr. Perazi, and Dr. Singla, who have been my kidney cancer, kidney surgery mentors, and have taught me everything I know, and still continue to learn from them about nephron sparing surgery. So I just wanted to give them a shout out and say thank you for you all for listening in. I'm sorry that we had some issues with Zoom, but happy to take any questions. Guess unmute Dr. Adai.
Dr. Patel.
Yeah, of course. May you unmute Dr. Adai?
Yes.
Okay, thank you. Am I on?
Yes, you're on. I can hear you.
Yes.
Great. Thank you for such a wonderful delivery. Our experience in Kumasi is that most of our patients are coming in quite advanced stage of the disease.
Okay.
And I'm wondering what you are doing in America that is so special, that allows you to pick up these tumors in the early stages to allow for these partial nephrectomies.
Yeah, so that is the, I guess that is really due to emergency departments coming in, and unlike a lot of places around the world, the US, based on our healthcare system, patients undergo cross-sectional imaging for everything. Dr. Dai, you would be surprised that how many CT scans are being ordered for stuff that are quite trivial. And sometimes I'm like, I don't understand, like an ultrasound would be sufficient, but CT scans are being done, and that's just the way to find things. And so we incidentally find renal masses so we incidentally find renal masses, and then they find their way to urologists earlier on. So we're seeing that people are just showing up and getting referred to us early on because they're being picked up on CT scans. And that's just a way that medicine is just done here, is emergency departments are just getting CT scans for patients really with back pain or abdominal pain. That's really just the first line of kind of imaging modality.
So is it to suggest that patients coming should have routine or ultrasound, just abdominal ultrasound, be able to pick most of these tiny tumors?
That's a good point. And obviously ultrasounds are relatively cheap, no radiation, and ultrasounds are good for picking up renal masses. And so if the patient, I mean, I can tell you numerous times where we were consulted, like patients coming in with an appendicitis, and they just did the fast, or they did a quick focused or a CT scan, and they found the renal mass and tell us. So if the emergency departments are having patients come in with at least in Kumasi, have patients coming with back pain or abdominal pain, I'm not sure if they do, but maybe a renal bladder ultrasound may help, especially if they're in that risk category. Say if they're a smoker or elderly or a male, then yeah, that may be warranted. I mean, it's a good idea, and it's relatively cheap, and it's no extra radiation. So.
Thank you.
Yeah, and then one more talk about cooling the kidney in various approaches. Yeah, so really cold ischemia time. And my old mentor, Dr. Derwish, did a lot of work with this, especially when he was a fellow at Cleveland Clinic. And I think a lot of the data comes from Cleveland Clinic. But when we're doing cooling the kidney, and I didn't talk about this, and I can mention this too, is really two things. We cool the kidney in really one patient selection nowadays, one or two patient selections. One is when we're doing an open partial nephrectomy. Usually those patients have some issues. That reason why we're doing open partial nephrectomy, not doing a minimally invasive approach. Say it's a very large tumor and it's probably maybe a pathologic T3. And so those patients, or the indication to do it, are pretty high. So we want to preserve as much renal function as possible. And there's data to support that cold ischemia time is better. So usually in those situations we're usually mixing, we have ice and that's mashed into a slush and mix it with normal saline or sterile water, and we kind of make into almost this, what we call a slushy, and pour it around the kidney and cool the kidney that way. And we also put cold lap pads soaked in ice water behind the kidney to help prop it up. And we constantly have, when we're sewing and stuff and we're touching the kidney, we constantly have our assistants kind of squirt a little ice water on our hands to help keep things cool. In minimally invasive approaches, you can see how it'd be technically hard, especially intra-abdominal, in the abdomen when everything's closed, the body temperature is warm. It's hard to. So we actually put an assistant port on top, right above where the tumor is, so a 5mm port, and we drop ice directly on top of the kidney, and we try to sit and keep the kidney on there as much as we can. And that the bedside assistant, or whoever is the assistant surgeon, is really in charge of kind of helping put the ice on the kidney. Finally, I didn't mention this, but the use of mannitol. We tend to use mannitol 25 milligrams. So we split it 12.5 and 12.5. So 12.5 we usually give up front before we clamp the renal hilum. And we do 12.5 after we unclamp the renal hilum. And we usually do that in patients with GFRs less than 45 to help decrease that oxidative stress. The data is not so strong in that. However, there is some data to support that. So I know some of my mentors have used that before, and they use that GFR 45 cutoff and do give mannitol as well as cool the kidney. Any other questions?
Oh, yes, my hand is up again.
Go ahead.
Great. So a study we did here in Kumasi revealed that most of the nephrectomies that were being done here, the average age was between 30 and 40. That is the average age. And we know from literature that renal cell carcinoma is a disease of the the fifth or sixth decade. And so I was wondering, per your experience, what is happening in the United States, and what should you do as a urologist here in Ghana?
So so they're coming between the age of 30 and 40, you're saying, most of the radical nephrectomies you're doing?
That's right.
So,
and they are coming with very huge tumors, actually.
So that leads to the issue of whether there's some genetic stuff going on, or are these kind of papillary necrosis and sickle cell patients. Those patients who present that early on tend to have more genetic mutations and alterations than the standard patient. And I can tell you that our patients that we've seen here who are advanced disease that young, which we get a fair bit about. We actually get a lot of referrals for advanced disease in young patients between 30 and 40 out here at Hopkins. And we see a lot of metastatic patients at presentation, and a lot of them have these genetic alterations, and whether it's VHL or they have some sort of other issue. Then the other issue is whether there's some environmental issue kind of going on, and whether there's some sort of exposure that's causing patients, because that's very young. In terms of how many, that would be very interesting to see that data, Dr. Dai, if you can share that with me.
It's a published data. It's published.
Okay.
Nephrectomy.
If you don't mind, okay, I'll look it up, and otherwise I can email you. Be interested, and I can email you back after I take a look at that and kind of give you some.
Okay.
We can chat about that, but that's very interesting. And it kind of leads me to believe that there's something else going on that we need to look into and try to see if we can help out.
Thank you.
Because that's very young. That's very young for advanced disease and needing to do a radical nephrectomy for those patients. That's very young for 30 to 40-year-olds. Most of our patients have some genetic issue with if they're presenting that young.
Okay. Unfortunately, we are not able to do any genetic typing.
Yeah. Sometimes we can see. I'll look at that data, and then I'll reach out to you, and I'll email you, and I'm happy to chat more about it with you after I take a look at the data.
Okay.
In regards to the other question for hilum and enucleation, so it all depends. Most of the time, we try not to clamp the hilum during enucleation, since you're not cutting into a lot of the vessels, and you're not cutting into a lot of healthy renal parenchyma. We tend not to. If it is a very endophytic renal mass that's a solitary kidney, or they have it's a CKD, and we want to enucleate, then we do, and we almost make a cross, an X incision on the healthy renal parenchyma and dissect down to the enucleation plane and then enucleate it out. But for the vast majority, we tend not to clamp the hilum. It just preserves renal function, and you can tolerate a 300, 400, 500 cc blood loss. And so it tends to be fine in those situations. But if we know that's going to be a complex enucleation, then we tend to clamp, because 15 minutes of clamp time is worth it to get everything out safely and throw your sutures quick. Any other questions? Oh yeah, Dr. Dai, so I'll look into that, and I'll email you, and I'll take a look into that data and look at you. But yeah, that's very interesting that they're presenting that early. We'll have to see, but that's, I'll be curious to see what their scans look like in their pathologic stages were too, and see if these patients, if there's something else going on. Do you have another question? I think Dr. Dai has another question. Katie, if you can unmute him.
Yes. In our radical nephrectomies, we always go to the line of thought to, as it were, be able to approach the kidney and lift it up, elevate it into the wound before we do. We hardly I haven't been able to approach the kidney from the renal hilum. I wish you could give a little advice or demonstration as to how to get to the hilum and control the bleeding before you even mobilize the tumor.
So, so these are open or partial, or excuse me, open
No,
or laparoscopic.
no, open.
Okay, so the best way to do that, once you medialize all the bowel, and so is this a flank incision or anterior?
Yeah, mostly anterior or flank. We do both.
So the best way to do that, and I've seen this a lot of times when you have these big masses with all these collaterals, and just get to the hyaline. That's what we always do, is get to the hyaline for these big radicals. And the best way to do it is, the classic teaching is, once you mobilize the bowel medial, find your gonadal vein and the ureter. And if you're on the right side, the gonadal vein, and I would always stay on top of the IVC, because IVC is going to show you where the renal vein is. And so I, on the right side, always march north and up to the patient's head along the IVC on the patient's right side. On the left side, you use the gonadal vein and march along the gonadal vein, because the gonadal vein is going to drain into that left renal vein. And that's the best way to approach it, because posteriorly, you don't really get parasitics going posteriorly into that plane where the psoas muscle is. And so once you have that space where you see psoas, you see your IVC on the right, and your ureter's up, then you have that whole posterior plane where you can put your hand behind, and that's all safe. And then you just march along up the IVC to the hilum. On the right side, left side, same thing. Ureter should be up, psoas is behind you, and then your gonadal vein is right there in medial, and just dissect along the gonadal vein up to the renal vein. And then once you do that, then you just kind of clip or use any cautery you have, or clip and cut until you find the highest part of the hilum. And once you get then you can have one hand behind the kidney and come around it like this, because that posterior plane is safe. And once you have the anterior plane above the hilum safe, you can almost touch your two fingers, create that space, and then that's your whole hilum block. And then how do you separate each vessel and tie them off, or how do you take your hilum?
Yes. We actually are able to separate the artery from the vein and tie them separately.
Okay. Yeah. So I think that's usually the best way before getting the upper pole dissected off, just because that can be a little dicey and tricky for larger renal masses, as well as all these parasitics and getting into gerotas, because they all have these larger parasitics. So that's the way that we were always taught for our larger renal masses. When we know there's going to be a lot of blood vessels around, just go follow that triangle of the ureter up, your psoas is kind of posterior, and your gonadal vein or your IVC, and just march along there, and you'll always get to the hilum quick, and you'll get to the hilum without many parasitic blood vessels.
Great. Thank you very much.
I think I have. I can show you a quick clip if you want. I have another video. Would you like to see that, Dr. Day?
Yes.
It's not open, but it's a robotic, but the same principles.
Okay.
Let me see if I can pull it up for you real quick. So you can see, so this is this is a big partial nephrectomy we're doing, but you can see I'm going to set this plane up for you. So here's that space I was talking about. So your ureter is up and your vein is down on here. This is on the right side. So we use the gonadal vein down here, and the ureter is up, and here's that you see that psoas space right there? And see that space right there, and then so they'll flip that gonadal down and get the ureter up. and keeping the gonadal vein down in this situation, or medial, just like an open procedure it's the same concept. You want to keep that medial, and now you keep the ureter, which is up there. And so now you have that whole safe plane back there. And once you do that, you can really elevate and get, you'll see how we move this other arm, get underneath there. And that's all safe space. There's nothing posterior about there besides the psoas muscle. And you really create this little triangle right here. And then you just take these in little packets and go. So you get that good safe lift. And then same thing though, in the open case, you just do that. And then now you're just peeling all this stuff away. And then you'll get to the hilum following the vein down below. All right, any other questions? Katie, anything else?
I can't see anything else.
Okay. Thank you, Dr. Adai. I appreciate you giving me an hour to talk about nephron sparing surgery. Hopefully one day I can come back and visit you guys. Maybe we can do some cases together. Is everyone still muted?
I think they are not. They can talk if they want to. But thank you so much.
Yes, thank you. I've been waiting to say my closing comments, but I've been muted.
Oh, you were.
But I want to say it's been a great lecture. It's been quite enlightening, and we are very grateful for this lecture. We're hoping and we're looking forward to the lecture on testicular cancers.
Yeah.
I hope you have filled up your dates for that one.
I think we have a July date, right?
That's right. That's right.
Yeah. Yeah,
Okay.
I should be able to do that. But yeah, anything else, let me know. And then I'll try to look into I'll try to find your data otherwise, and I'll chat with you via email and get in touch.
Yeah, it's adult nephrectomy in Komfanochi Teaching Hospital, Kumasi.
Okay. Tell everyone at the hospital I say hello. I miss everyone.
Yes, I'll tell them. And unfortunately, your friend JB couldn't say hi because he lost his connection. Yeah. And has been trying since to get back online. Oh no. And it's not been successful. Oh. So I will extend. Yeah, it's been. And I hope Kachi will share the video with us, the recording. And so I will share with the rest of the team that couldn't join.
Sounds good.
Yeah, absolutely.
Pleasure chatting with you guys, okay? Everyone have a great evening.
Yeah, thank you so much.
Thank you, Katie.
Okay.
Sorry for the technical issues.
Well, I'm sorry.
All right, take care, everyone. Bye. Bye, Dr. Day.